the most common gastric tumors that we encounter are gastric polyps, and they include hypoplastic polyps, inflammatory polyps, hematomatous polyps, and neoplastic polyps. अच्छा, इन polyps में से जो polyps सबसे ज़्यादा tumors के साथ associate हैं या pre-neoplastic हैं या cancer को predispose करते हैं, वो neoplastic polyps होते हैं. Now, inflammatory and hypoplastic polyps account for up to 75% of all gastric polyps. They are associated with chronic inflammation, and that is the main driving force. Or if you remember, the main cause of chronic inflammation or chronic gastritis was Helicobacter pylori infection. So, इसलिए जिन regions में Helicobacter pylori infection ज़्यादा होता है, वहाँ पर hypoplastic और inflammatory polyps ज़्यादा होते हैं. They are more common in 5th to 6th decade of life because obviously they need time to develop. So long-standing chronic gastritis की usually setting में arise करते हैं. Polyps may sometimes regress after bacterial eradication. So if you give them the triple regime, they are eradicated. Fundic gland polyps. Fundic gland polyps occur sporadically and in individuals with familial adenomatous polyposis. So they are at increased for development of colorectal carcinomas and other tumors at other sites. We will do FAP more in detail when we do large bowel tumors. Prevalence has increased due to increasing use of proton pump inhibitors. Fundic gland polyps may be asymptomatic or associated with nausea, vomiting, or epigastric pain. Now, coming to gastric adenomas, they represent up to 10% of all gastric polyps. Frequency increases with age. Prevalence parallels the incidence of gastric adenocarcinoma. So, because one of the risk factors for development, or they are basically pre-neoplastic lesions. So, or pre-neoplastic lesions or precursor lesions. Better word would be precursor lesions. तो जहाँ जिन populations में gastric adenoma कॉमन है, advanced वही usually advise progress करके carcinoma को arise देता है. तो gastric adenocarcinomas gastric adenocarcinomas are more common, mimic the prevalence of gastric adenomas. Males are affected 3 times more commonly than females. Incidence is increased in individuals with familial adenomatosis polyposis. Risk of adenocarcinoma is particularly increased in lesions greater than 2 centimeters. This is true also in the large bowel. तो जहाँ जैसे जैसे adenoma का size बड़ा होता चला जाएगा, कार्सिनोमा का रिस्क बढ़ता जाएगा. मेक सेंस, क्योंकि उतने ही मोर सेल्स हैं जहाँ पे वो डिवीजन हो रही है और जेनेटिक म्यूटेशंस अकर कर रही हैं. तो जितना बड़ा पॉलिप होगा उतना ज़्यादा चांस होगा कि उसके अंदर एडिनोकार्सिनोमा प्रेजेंट है. ओवरऑल कार्सिनोमास में भी प्रेजेंट है up to 30% of gastric adenomas. Now, gastric adenomas, adenocarcinomas. Most common malignancy of the stomach is the gastric adenocarcinoma. It is divided morphologically into 2 types, intestinal type and diffuse type. बहुत आसान है. जब माइक्रोस्कोप में हम नीचे के अंदर देखते हैं तो अगर सेल्स ग्लैंड्स बना रहा होता है, ट्यूब्यूल्स बना रहा होता है, तो उसको प्रीडोमिनेंटली तो उसको हम इंटेस्टिनल टाइप कह देते हैं. और अगर सेल्स इंडिविजुअली और ग्लैंड फॉर्मेशन एग्जिबिट नहीं कर रहे होते तो उसको हम डिफ्यूज टाइप कर देते हैं. इसकी इंपॉर्टेंस है, अभी हम आगे देखते हैं. Early symptoms of both types resemble those of chronic gastritis and peptic ulcer disease. Tumors unfortunately are often discovered at advanced stages. Or this is why gastric adenocarcinoma has a poor prognosis. And usually at the time of diagnosis, the tumor has usually very frequently crossed the muscular layer and gone into the serosa or the adventitia part and into the peritoneal cavity. And sometimes gastric adenocarcinoma is unique in the sense that the initial presentation is a metastatic phenomenon. यानी कि डिस्टेंट मेटास्टेसिस के साथ प्रेजेंट करता है. Gastric cancer incidence varies markedly with geography. In Japan, Chile, Costa Rica, and Eastern Europe, the incidence is up to 20-fold higher than in North America, Northern Europe, Africa, and South Asia. So this marked distribution helps us understanding that probably there's a genetic as well as a environmental factor to the incidence of gastric carcinoma. The meet now stark contrast. Sites most commonly involved now, because as I told you, gastric carcinoma is one of those tumors which frequently presents as distant metastasis, and they have very unique presentation. So we have given them, they're so fairly common that we have given those presentations or those clinical settings as special names. So if the patient presents with a supraclavicular enlarged lymph node, we label it as Virchow's node. If the patient presents with periumbilical lymph nodes or periumbilical subcutaneous nodules, it is labeled as Sister Mary's or Joseph nodule. If a patient presents, the initial presentation is with a left enlarged axillary lymph node, it is called the Irish node. If the tumor presents as an axial mass or a abdominal mass and it is involving the ovaries, it is called a Krukenberg tumor. And if it involves primarily the pouch of Douglas, it is called a Blummer's shelf. And these are fairly common presentations. Any patient rectal bleed, yeah, adnexal symptoms, yeah, fertility symptoms के साथ present कर सकता है, axillary lymph node के साथ present कर सकता है. So these can be, they are so common distant metastasis as the initial presentation कि इनको हमने खास नाम दे दिए. तो if you heard the word Virchow's node, it means we are talking about metastatic adenocarcinoma of the stomach. Likewise, अगर periumbilical nodes बड़े हुए और वो positive आते हैं cells with carcinoma cells, तो chances हैं कि वो metastatic adenocarcinoma है stomach से. So and so forth. Okay. Gastric cancer is most closely linked to Helicobacter pylori prevalence. तो जिन regions में Helicobacter pylori infection ज़्यादा है, उन regions में भी हम देखते हैं कि gastric carcinoma का incidence ज़्यादा है. Another contributor is consumption of dietary carcinogens such as N-nitrosamine compounds and benzopyrene, so formed during the salting and smoking of the fish. और इसीलिए ये जापान में और इन countries में fairly common है, क्योंकि उनकी कल्चरल यूज होती है स्मोक फिश और प्रिजर्वेटिव्स यूज करना फिश के लिए. Now, loss of E. cadherin is a key step in development of diffuse gastric cancer, and loss of function mutation in tumor suppressor gene CDH1, which encodes E. cadherin, are seen in greater than 50% of cases. Now, this is very important because usually होता ही है elsewhere भी कि ट्यूमर के सेल्स को एक दूसरे से अटैचमेंट जरूरी होती है सर्वाइव करने के लिए, तभी वो एडिनोकार्सिनोमा के सेल्स जो हैं वो ग्लैंड बनाते हैं यूजुअली. बट गैस्ट्रिक कार्सिनोमा के सबसेट में बहुत यूनिक प्रॉपर्टी होती है कि ये ई कैडहेरिन लॉस की म्यूटेशन हो जाती है, जिससे द सेल्स कैन सर्वाइव इंडिपेंडेंटली. दे डोंट नीड टू कीप स्टिकिंग टू ईच अदर, इसलिए अलग अलग हो जाती है. और हेंस द टाइप डिफ्यूज टाइप, अभी जो हमने मॉर्फोलॉजिकल दो टाइप्स की थी, इंटेस्टिनल टाइप और डिफ्यूज टाइप, तो डिफ्यूज टाइप में यही प्रॉब्लम होता है कि क्योंकि सेल की जो कैपेसिटी है, मतलब उसको जरूरत नहीं होती कि वो दूसरे सेल से अटैच रहे, वो इंडिपेंडेंटली भी सर्वाइव कर सकता है. तो दिस इज कॉल्ड, दिस गिव्स द सेल द एबिलिटी टू सर्वाइव ऑन इट्स ओन. और इसीलिए वो डिफ्यूज अलग 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 सेल्स पड़े हुए होते हैं ट्यूमर के अंदर, इसलिए डिफ्यूज टाइप कहते हैं. इट डज नॉट नीड टू फॉर्म ग्लैंड्स. E. cadherin expression is drastically decreased in rest of the tumors, often by hypermethylation, यानी कि epigenetic pathway से E. cadherin silence हो जाता है, और this gives the cell the capacity to survive on its own and does not need to form glands. Sporadic intestinal type gastric cancers are strongly associated with mutations of the WNT pathway, and they include loss of mutations in the APC tumor gene and functions of gain of functions of mutations encoding the बीटा कैटेनिन जीन. तभी ये एडिनोमा कार्सिनोमा सीक्वेंस जो हम लार्ज बाउल करेंगे उस वक्त डिटेल में देखेंगे. So they usually give rise to intestinal type of gastric adenocarcinomas. Other tumor suppressor genes have also been identified, including those involving in the TGF signaling pathways, regulation of apoptosis or BAX gene, and cell cycle control. इसमें बस ये इम्पोर्टेंट याद रखना है कि जो ई के adhesion वाला लॉस है वो जरूर पता होना चाहिए क्योंकि वो यूनिक है. ये एक एडिनोकार्सिनोमा ऑफ द स्टमक के लिए और ये यूनिक है. और ये पता होना चाहिए कि इंटेस्टिनल टाइप्स में यूजुअली एपीसी जीन और बीटा कैटेनिन इन्वॉल्व होते हैं. सो यू कैन सी, एज यू कैन सी, देयर इज ग्लैंड फॉर्मेशन. एक ग्लैंड फॉर्म हो रहा है, तो दिस इज अ गैस्ट्रिक एडिनोकार्सिनोमा ऑफ इंटेस्टिनल टाइप. सही है, ल्यूमन बन रहे हैं और मतलब बेसिकली ग्लैंडुलर ल्यूमन बन रहे हैं. और ये इंटेस्टिनल टाइप है. देखिए एक एक सेल पड़ा हुआ है आपस में जुड़े हुए. अब बाहर इसलिए लग रहे हैं कि ये करीब करीब बहुत हैं, बट if the individual cell can survive on its own, it does not need the glandular structure. So frequently these tumors will show loss of expression of EK adherent. Now there are other dissimilarities in the intestinal and diffuse types. Intestinal gastric carcinoma predominates in high-risk areas and develops from precursor lesions, including flat dysplasias and adenomas. The mean age of presentation is 55 years. Male to female ratio is 2:1. Incidence of diffuse gastric cancer is relatively common, and there are no identified precursor lesions. Disease occurs at similar frequencies in males and females. So it is the gastric intestinal type that we can prevent by good screening methods, because there's a lesion that we recognize that can as a precursor lesion, and those are gastric adenomas or dysplasia. So if we catch the tumor at that stage, we can improve the prognosis. And as it was, we saw in esophagus, depth of invasion is the single most important, or the T stage is the single most important predictor of outcome. Depth of invasion, extent of nodal and intestinal metastasis and diagnosis remain the most powerful indicators in gastric cancer. With surgical resections, 5-year survival rate of early gastric cancer can exceed 90%. But unfortunately, in most parts, the 5-year survival is poor because the presentation or we pick up disease late. But in high prevalence areas like Japan, there's a very robust screening program. So they have really markedly reduced the incidence of late stage gastric cancer, and they because of extensive screening programs, they pick up the lesions very early, and the mortality rate of gastric carcinoma has really gone down in Japan. Now, another important tumor that frequently involves, well, it's not as frequent as gastric adenocarcinoma, but nonetheless, it's a fairly common tumor, is gastric lymphomas. Although gastric lymphomas can arise in any tissue, they do so most commonly in the gastrointestinal tract, particularly the stomach. About 5% of gastric malignancies are primary gastric lymphomas, most common of which are extranodal marginal zone lymphomas. अच्छा, अब देखो इसमें ज़रा ट्रिक है, टेक्स्ट के हिसाब से यही है, बट हमारी पॉपुलेशन में परहैप्स ज़्यादा कॉमन जो है वो गैस्ट्रिक डिफ्यूज लार्ज बी सेल लिम्फोमा है, एंड इट इज़ नॉट गैस्ट्रिक lymphomas. Probably because अभी हम देखेंगे जैसे कि these marginal zone lymphomas have a tendency to progress to diffuse large B-cell lymphomas. So probably a subset of diffuse large B-cell lymphomas that we see are lymphomas that have progressed from marginal zone lymphomas, picking up more mutations and transforming into diffuse large B-cell lymphomas. So anyways, in gut, these tumors are more. तो अगर MCQ में आ रहा है तो किताब ये कहती है कि the most common lymphoma of the gastrointestinal tract is the marginal zone lymphoma, or of the gastric of the stomach is मार्जिनल जोन लिम्फोमा, तो आपने मार्जिनल जोन लिम्फोमा ही ट्रू करना है. In gut, these tumors are often referred to as lymphomas of mucosa associated lymphoid tissue or maltomas. Extranodal marginal zone B cell lymphomas usually arise at sites of chronic inflammation. That is why सबसे ज़्यादा common cause of chronic inflammation in the stomach is chronic gastritis. Chronic gastritis का main reason क्या है? Helicobacter pylori infection. So it is very strongly associated with Helicobacter pylori infection. Now, if you remember in general pathology, the only bacteria that we knew was established to be oncogenic was Helicobacter pylori. So Helicobacter pylori is a precursor or a predisposing factor or a risk factor for two gastric tumors, adenocarcinoma of the stomach and gastric lymphomas. In stomach, maltoma or malt lymphoma is induced typically as a result of chronic gastritis or chronic Helicobacter pylori infection. 3 translocations are seen and are associated with gastric maltomas. The most common is translocation of chromosome 11 to chromosome 18 from long arm of chromosome 11 to short arm of chromosome 18. The less common are D114 translocation and T14 and 18 translocation. And these are sites of एंटीबॉडी सिंथेसिस, इसलिए ये जनरली बी सेल्स को इन्वॉल्व करते हैं. सही है ना? बी सेल मैच्योरेशन में ये सारे प्रोटीन इन्वॉल्व होते हैं. All mutations have the same net effect, constitutive activation of nuclear factor kappa beta, a transcription factor that promotes B cell growth and survival. Most common presenting symptoms are dyspepsia and epigastric pain, because obviously, as I told you, कि chronic gastritis की setting में होती है तो similar जो symptoms हैं वो overlap करते हैं. Hematemesis, melena, and constitutional symptoms such as weight loss can occur, and generally they are a marker that the chronic gastritis has progressed to something more sinister. Now, something very interesting about maltomas is it's one of those few tumors which in early stages can be treated with Helicobacter pylori eradication only. Because what happens is, if you come over here, ये जो ये factor है, activation of nuclear factor kappa beta, अब होता ये है कि basically ये सारी growth promoters हैं, ये जो सारी mutations involved कर रही हैं, ये सारी growth promoter regions हैं, सही है? तो क्या होता है कि in absence of these mutations early on in the process, what happens is chronic gastritis acts as a trigger for the release of nuclear factor kappa beta. क्योंकि वो chronic inflammation होती है, cytokines release हो रहे होते हैं, तो एक ऐसी environment मिल रही होती है जहाँ पे cytokines बहुत present होते हैं और and they drive the promotion or the proliferation of chronic inflammatory cells. With time, what happens is when the lymphoma picks up these mutations, it becomes independent of the presence of Helicobacter pylori, and then the lymphoma can grow in a autonomous fashion. जब तक ये mutations occur नहीं होती, what happens is because of the Helicobacter pylori chronic gastritis, cytokines are released, and this keeps on activating this or ordering the cells to release nuclear factor kappa beta, and this drives the B cell proliferation. So if you treat the patient for Helicobacter pylori, you take away the chronic gastritis, you stop the release of cytokines, which causes decrease in the release of nuclear factor kappa beta, and that can stop the proliferation of the B cells. So in early stages, you can treat with Helicobacter pylori eradication only. You don't need to give chemotherapy. But with time, when the tumor picks up those mutations, then what happens is the patient becomes, even then if you treat with Helicobacter pylori gastritis, the patient will not respond and you will need to give chemotherapy. अच्छा, अगर कोई चीज समझ में नहीं हो इस वाले क्वेश्चन में, तो we can ask questions at the end of the lecture. Now, carcinoid tumors. Carcinoid tumors are also not very uncommon, although they are more common in the the small bowel and the terminal ileum and appendix and elsewhere in the gastrointestinal tract, but they can involve the stomach also. They arise from diffuse components of endocrine system that are now properly referred to as well-differentiated neuroendocrine tumors. These tumors can involve the gastrointestinal tract, the tracheobronchial tree, and lungs also. The peak incidence is in 6 decade. Symptoms include are determined by the hormones that are produced. So if the tumor produces gastrin, the patients will present with peptic ulcer disease or Zollinger-Ellison syndrome. If the tumor produces, uh, sometimes the tumors rarely can produce other vasoactive peptides, so they may produce diarrhea or other symptoms. And sometimes the tumor may produce insulin, though pancreas is most common for that phenomena too well. So patients can present with insulinomas and diabetes. Sorry, with recurrent episodes of hypoglycemia. Okay, so this is an overview of gastrointestinal carcinoids. I'll only be touching the stomach. Of the total carcinoids, almost 10% involved the stomach. The mean age of presentation is 55 years. The common site is fundus because that is where the most neuroendocrine cells are present naturally. Size is usually small, 1 to 2 centimeters. Rarely they can be more than 2 centimeters. They may be associated with release of histamine, somatostatin, and serotonin. Um, um, the symptoms include gastritis and ulcer formation, especially if they are associated with histamine release, or rarely if they are associated with gastrin release. The behavior is variable. Generally, uh, the larger the size, the more the chances of them behaving in a more aggressive fashion. And as they are tumors of the neuroendocrine system, they are associated with MEN1 syndrome and atrophic gastritis. Atrophic gastritis because um, what happens is basically the patients have achlorhydria, which gives there's a negative feedback. Because of achlorhydria, what happens? Gastrin is released, and that causes neuroendocrine cell hyperplasia, and that gives the patient or predispose the patients to develop neuroendocrine tumors because there's a background of neuroendocrine hyperplasia. Now, another tumor that is unique to the gastrointestinal tract is the gastrointestinal stromal tumor. They are, although a lot of other soft tissue tumors can also involve the gastrointestinal tract, but they are fairly uncommon. The most common is the gastrointestinal stromal tumor, or as we commonly call it as GIST. It is the most common mesenchymal tumor to gastrointestinal tract, and most occur in the stomach. Peak age at which clinically evident GIST are recognized is approximately 60 years, with fewer than 10% occurring in individuals younger than 40 years of age. Carini's stride is a non-hereditary syndrome seen primarily in young females. These include gastric GISTs, paraganglioma, and pulmonary chondroma. There is also an increased risk of GIST in patients with neurofibromatosis type 1. Now, 75 to 80% of all GISTs have oncogenic gain-of-function mutations in receptor tyrosine kinase KIT or c-KIT. This is also one of those mutations that you need to know, and this is important because एक तो ये fairly इसके लिए it is present in most of the GISTs, and it has a therapeutic implication because we have a medicine called imatinib, which is anti-CT117 और anti-c-KIT, और ये anti-c-KIT जो है target therapy होती है against this receptor, and it is used in treatment of GISTs. तो इसलिए इसकी therapeutic implications होती है. 8% of GISTs have mutations that activate related platelet growth factor, alpha, PDGFRA. Rarely, loss of SDH function mutations are often seen in inherited germlines and confer an increased risk for GIST and paraganglioma. And these patients do not respond to anti-CD117 therapy. तो इसलिए इसकी इम्पोर्टेंस होती है कि the oncologist asks you कि इसमें c-kit positive आ रहा है कि नहीं आ रहा है. सही है? So you can do this test on immunohistochemistry as well as on molecular tests. Symptoms of GIST are generally related to mass effects. Approximately half of individuals present with anemia or related symptoms. So, and unfortunately, probably usually because it's generally they are slow-growing tumors. They present with when the tumor is more than 4 or 5 centimeters generally. See, and size is a recognized risk factor. So the greater the size, the more aggressive the lesion or the tumor is likely to be. Frequently, there are incidental findings during radiologic imaging, endoscopy, or surgery performed for other regions. And generally, because they are incidental findings, they tend to be small and they carry a good prognosis. Surgical resection is the primary treatment for localized GIST, but for recurrent GIST or for unresectable disease, imatinib therapy or anti-CD117 therapy is a viable option. And these patients sometimes do very well with anti-CD117 therapy. Prognosis correlates with tumor size, mitotic index, and location. Gastric GISTs are relatively less aggressive than those of the small intestine. Likewise, mitosis or Chi67 index, the more the mitotic figures or the higher the Chi67 index, the more aggressive the tumor is. Many tumors fall into an intermediate category. As I told you, GIST with mutations in c-kit or PDGFRA often respond to tyrosine kinase inhibitor therapy. इसलिए you need to know this gene mutation, these gene mutations. And it will generally present as a polypoidal mass, or it will present as a mass that seems to be pushing from the stomach wall into the gastric lumen. See, because it's basically a tumor that is centered into the muscular layer. And it is thought to be arising from tumor cells of intestinal cells of Cajal, which are the pacemaker, considered as a pacemaker of the stomach. And under the microscope, it will show these classic spindle-shaped cells. See, fascicular pattern hota hai, and these will be positive for CD117. Another marker that is unique, or you might see in MCQ, especially in those of you who are interested in giving steps, is DOG1, DOG, capital silicon DOG-1, which is a marker or immunological marker, which is it was just first discovered on GIST, so that is what DOG1 stands for, discovered on GIST1, and it is present in over 95% of gastrointestinal stromal tumors. It is more sensitive as a marker for picking up GIST than CD117. Okay, this is it. Now, हिस्टोलॉजी आप लोग पहले कर चुके हैं प्रैक्टिकल में इन सब ट्यूमर्स की, तो कोई क्वेश्चन हो तो फील फ्री टू आस्क मी. चैट काम गई जी. एनी क्वेश्चंस? How do PPIs cause funding gland polyps? Basically, PPIs cause funding gland polyps in the sense that होता ही है कि patients who are on long-term proton pump inhibitor therapy, their gastric secretions are decreased. जब वो gastric secretions decrease हो जाती हैं, तो what happens is कि जो cytokines हैं, sorry, जो gastrin levels हैं, वो बढ़ना शुरू हो जाते हैं, और जो बेसिकली नेगेटिव फीडबैक के थ्रू जो पैराइटल सेल्स हैं उनको ऑर्डर ये मिल रहा होता है कि या जो प्रोड्यूस मोर एसिड, और that causes release of cytokines and growth factors in the gastric fundus. Because all the parietal cells are focused are centered in the fundus, which drives the proliferation of fundic cells, and that causes fundic gland polyps to occur. सही? Does that answer your question? Roll number कौन था? सॉरी, वो सवाल एक मिस हो गया, शायद ऊपर चला गया, तो कोई जिसके बारे में कोई दूसरा सवाल पूछ रहा था. हाँ सर, कैन यू रिपीट द मार्कर यू सेड वाज सेंसिटिव फॉर जिस? डॉग 1, DOG1 डिस्कवर्ड ऑन जिस्ट. तो पहला डिस्कवर्ड का D, ऑन का O और जिस्ट का G -1, dog 1. It is like this, dog -1. ओके, बट इसकी कोई थेरेप्यूटिक एप्लीकेशन नहीं है. थेरेप्यूटिक एप्लीकेशन जो है वो CD117 की है और सीकिट की है. सही है. तो 3 मार्कर्स आज हमने देखे थे जो कि इम्पोर्टेंट है. इकेडहेरेंट लॉस इन डिफ्यूज टाइप गैस्ट्रिक एडेनोकार्सिनोमा, CD117 और सीकिट और जिस्ट. सही. अच्छा, वो हेलिकोबैक्टर पाइलोरी एरेडिकेशन वाली बात सबको समझ में आ गई थी? How in early stage, when the tumor has not picked up those mutations, if you treat with Helicobacter pylori eradication therapy, because the tumor has not picked those mutations, you take away the chronic inflammation, which is the driving force in the initial development of gastric lymphomas. और वो क्योंकि वो ड्राइविंग फोर्स या जो ट्रिगर एक्ट कर रहा होता है एज ऑन्कोजीन, वो रिमूव कर देते हैं, तो पेशेंट्स सही हो जाते हैं. So it is one of those lymphomas that in early stages you can treat with Helicobacter pylori eradication only. 15 दिन की एंटीबायोटिक खाएं और आप कैंसर से और लिम्फोमा से निजात पाएं. बट एडिनोकार्सिनोमा में ऐसा नहीं है. Once adenocarcinoma develops, treatment with Helicobacter pylori will not regress the tumor. It's only true for gastric lymphomas. हिस्टोलॉजी में कोई क्वेश्चन हो? युसरा,
जी सर.
जी, मेरे ख्याल में कोई क्वेश्चन तो आ नहीं रहे.
ठीक है सर.
सही. तो
जी जी.
वो 1-2 मिनट और वेट कर लेता हूँ. किसी को कुछ कोई स्लाइड्स गो थ्रू कर लो. कोई क्वेश्चन हो तो पूछ सकते रहिए. वो मैंने बुक की सॉफ्ट कॉपी अपलोड की हुई थी, तो उससे भी जब आप ये पढ़ें तो कोई क्वेश्चन हो तो नेक्स्ट लेक्चर में भी यू कैन फील फ्री टू आस्क. सही. आई थिंक फिर सही. कोई क्वेश्चन नहीं?
जी सर. ठीक.
सही. थैंक यू.
जी सर. थैंक यू सर.